The following podcast is part of a certified educational activity titled Understanding the Individual in Front of You, the Importance of Patient Participation in Weight and Glycemic Management for People with Type 2 Diabetes. Access the entire activity and complete the post-test at peerview.com/EYG860. Downloadable slides and practice aids are also available.
Hello, I'm Melanie Davies from the University Hospitals of Leicester NHS Trust in Leicester, UK. Welcome to Understanding the Individual in Front of You, the Importance of Patient Participation in Weight and Glycemic Management for People living with Type 2 Diabetes. Joining me today are my colleagues, Tina Visbal from the University of Copenhagen in Copenhagen, Denmark. Welcome, Tina.
Thank you.
And also Denise Franco from the CP Clinical Research Center in Sao Paulo, Brazil. Welcome, Denise.
Thank you.
So our goals for the session today are to really augment your understanding of the effects of weight loss on glycemic and non-glycemic health goals, to equip you with strategies for holistic, individualized care for people living with type 2 diabetes, and provide guidance on incorporating shared decision-making and multidisciplinary management into clinical care. So I just want to set the scene. So when we talk about this framework of decision-making in people with type 2 diabetes, and in this session, taking the right steps in the correct sequence at the right time. So firstly, if we look at the ADA ESD consensus report, which was last updated in 2022, we have a figure right at the beginning of the document that puts the person living with type 2 diabetes right in the front of center of everything we do, with really the aim in terms of improving quality of life, and also preventing complications. So we really want to optimize quality of life in people living with diabetes and reduce the burden of complications. There's a decision cycle which really starts with the person and their key characteristics, and then goes around this cycle talking about specific factors that impact our choice of treatment and this use of shared decision-making to create a management plan that we agree, implement, and monitor and review very actively. In the ADA ESD consensus, one of the things that we prioritized in a new way was really thinking about weight management alongside glycemic control and cardiovascular risk factor protection. We really recognized that weight management is really a pivotal intervention. And we talked about a target of at least 5% and often up to 15% as a primary target for people living with type 2 diabetes. So we have the person at the center. We have these principles of care, including shared decision-making, which we'll talk a little bit more about later on. And then these four components of care: glucose lowering, weight management, cardiovascular risk factor management, and cardiorenal protection. And all of these are equally important. So that's what we really mean, I think, around the holistic approach to care. But let's hear from a person living with diabetes. I want to introduce Joachim. Let's hear from him, a person who has dealt with type 2 diabetes and obesity for a number of years.
Well, I am an engineer, mechanical engineer. I am 68 years old, and I worked with engineering for almost 20 years. And then I started working with other stuff than engineering, but sales, administration, or all other stuff. But I'm still an engineer. So I was born in a big city. Sao Paulo is a pretty big city, and over 12 million people. I think it's the third or fourth largest city in the world. Pretty busy place, pretty crowded, polluted quite a bit. As a child, I was a little fat, yes. When I got to the university, I lost the weight. I was very thin during the university. And when I got married, I got fat again. After 26, which is the age that you stop being, let's say, vulnerable. That's my thinking. But then I started growing up a little bit. Yes. I lost my hair. 26, 27, I was already bald. Well, I started having, let's say, high pressure problems at 42, 43 years old. And I noticed that as my father had, I also had that. And my father, unfortunately, he passed away and he smoked it quite a bit. So he had 2 or 3 heart attacks until he had a broken heart rate. Well, I had problems with my hip and with my knee. In 2018, I have to replace the hip. And it was really hard. Recover took about 3 to 4 months and was really hard. And because I spent so much time with the hip with problems, I use a cage, and I probably have overloaded the knee on the other leg. So in 2020, I had to replace the knee.
So it's really interesting, Denise and Tina, listening to Joachim's story. Tina, how frequently do you encounter people in your clinic who've been living with diabetes and obesity since a very young age?
Well, unfortunately, it is very often. Type 2 diabetes we have to consider as a very heterogeneous disease. But unfortunately, a lot of the patients actually carry the overweight from childhood. We know with respect to childhood obesity on the other way that approximately 80% of children having obesity actually take it with them into the adulthood. So it is unfortunately very often.
Yeah, and Denise, Joachim mentioned his orthopedic problems and joint damage. Do you see that commonly in the clinic in people related to their overweight and obesity?
We know that is very common when you have someone that is facing obesity, and we know that more than 70% of the people with obesity will develop at least any of or osteoarthritis in their lifetime. So it's very common to see, just like talking, a lot of patients that comes to us arguing about that.
So he mentioned that he had to walk with a cage or a walker. We would talk about as well. So we have people living with mobility problems. How do you advise those patients in terms of physical activity?
It's very important to know the patient and how is the ability of the patient in order to individualize and try to focus what will be better for him and try to introduce. For instance, for him, we talk about that. We decide that going to swimming would be the better for him because it would be easier than to use other strategies. And the main thing, he argued that it would be possible for him to do that.
So thank you. So the key takeaways from this first section that we're going to talk about is considering patient preference and person-centered language, which are really key components that we talk about in terms of the principles of care in the ADA ESD guidelines. Weight management as a primary target. For many reasons, it can be disease modifying if we get really high levels of weight loss, and it can also improve metabolic control. And also the fact that we are prioritizing glucose lowering therapies that also take weight into account. So, Tina, I want to hand over to you now to talk about some of the practicalities and potentials of including the patient in decision making.
Yeah, thank you very much, Melanie. But I think before I dig a little bit more into details with that aspect, we should go back to Joachim and hear what he can actually learn us about and tell us about the treatments that he has actually received.
I started going to the cardiologist, which was the same one that treated my father. He is the guy that treated me most of the time. He's the guy that found that diabetes is starting. He's the guy that also told me that I should lose weight and get rid of some fat in my liver. So he was a kind of do it all. I started with metformin, and then he increased the dosage. I'm taking 1,000 milligrams. And then he started giving me the empagliflozin. It started with 5, then went to 10, and then 25, and I'm using 25 today, milligrams. Well, he said that I should do exercise. As I had problems with the hip and problem with the knee, the best thing to do was swim. So I swim 2 times per week for 50 minutes. And I also walk 3 times a week. I walk about 25, 30 minutes every other day. But about 5 years ago, I had a problem with the ear. I have an infection. And after 5 doctors, I get a problem solved. A doctor called Tester, which is a really good otorhinolaryngologist, he also saw that I have diabetes, and diabetes is bad for getting rid of infections. He also said that I should see an endocrinologist. When I got to Mrs. Franco, I started having the other one is it's many names, dapagliflozin, and there is also the semaglutide. So yes, I made that. Now I'm at 25, 14 milligrams. 14 milligrams of this one. Started with 3, went to 7, 3 for 1 month, 7 for 2 months, and then I'm at 14, or I think 2 months. I take a pill. I'd rather have a pill. The injection is for 7 days. And I don't believe the body would do a very good job on giving up that thing slowly. No, don't believe that. So I take every day what has to be done every day. I think my weight would be nice to be at 94, 95, which is I'm extremely close to. I have 1.83 meters tall, and this is going to get me to a very good position. My bones are very big, so I don't want to shrink, and I feel good this way. So that's the target. In fact, I'm already on the target, almost on the target. So I lost 25 kilos within a period of 5 to 6 years, or a little bit more.
So, as you heard from our patient here, life is often complicated, and often one drug take the other, and you need to trust your healthcare provider. You need to decide together where you're going. Often, for decades, we have started with metformin, but we also know that there is this very close correlation between overweight and obesity. And I just love the new, you could say they're not new anymore, but the recent consensus guidelines, because they focus, as we usually say, to the left of the guidelines on patients with comorbidities with respect to atherosclerotic cardiovascular disease, chronic kidney disease, and heart failure. And often we say they are actually the no-brainers because they need to have SGLT2 inhibitors or GLP-1 receptor agonist on board. But Joachim is actually to the right. He is suffering or challenged by obesity and dysregulation. And there we really had to focus on individualizing the treatment. We actually are fortunate by a lot of different options in our toolbox. metformin is still a backbone, especially in individuals without cardiovascular disease or high risk of cardiovascular disease. It's a wonderful tool in the toolbox, and I use it on a regular basis. But thereafter, we had, based on the recommendations in the guidelines, to consider with a very individualized approach, where are we going from? How dysregulated is the patient? How obese is the patient? What mode of action do we want to target when we look at the phenotype of the patient? And we have different suggestions. We have the old-fashioned sulfonylureas. I don't use them very much. We have the more modern ones being, you could say, the DPP-4s, although they are not really saving lives, but they do still have a small place. But those that are really targeting a wide population, when you look into dysregulated individuals and people challenged with overweight, are the SGLT2 inhibitors and the GLP-1 receptor agonists, which have documented cardiovascular life-saving potential. But we should not forget insulin either as also an option. But recent years, insulin has been moved further and further down in the guidelines. What's important when we sit in front of each patient is to consider what is the right treatment, because that's another thing. What's really good about the consensus statement is that they do not only say that we have this class and this class and this class, but they actually prioritize not only between the classes, but also within the class. And today we know that the once weekly GLP-1 receptor agonist, and even those which are now dual agonists, are more efficacious in respect to both change in HbA1c, change in body weight. And what's the fantastic thing about GLP-1 based therapy in general is that it does not induce hypoglycemia. So using the more modern GLP-1 receptor agonists are indeed the most efficacious in respect to the things that I just talked about. However, there are also indeed patients who have chronic kidney disease where SGLT2 inhibitors are still the first choice. However, a lot of studies have now demonstrated that the combination of metformin, if indicated, if not too severe chronic kidney disease, combined with SGLT2 inhibitors and GLP-1 receptor agonists. Because there are indeed also, and I've been working within the GLP-1 based therapy for a very, very long time. And what we know is that the older ones, which were twice daily or once daily, they do have effect, definitely. But as you move towards the once daily, and when you then add GIP on board with the dual agonist, which is once weekly, then the efficacy is much more pronounced. Today, we see effects of HbA1c reductions of more than 2% and really, really beautiful effects of 10 to 15% body weight reduction in the patients with type 2 diabetes, which is really fantastic. When I was a young doctor, my old professor told me, don't bother about trying to change weight in individuals with type 2 diabetes because they simply didn't have the tools back then. So we are really in a place where we can focus, we can go beyond glycemic control, because at the same time as improving HbA1c, we can improve body weight. And then we have all the added effect of blood pressure decrease, lipid lowering effects, change in body composition, moving the visceral fat. And so it's really, really interesting to have tools with the medication, because still, I am a big fan of medication, but I'm also a big fan of lifestyle interventions. So, and it makes it easier to talk to the patients about exercise when you give them drugs that will have them lose weight. They're more motivated for taking the stairs. They're more motivating for doing what the dietitians tell them to do. So, in general, it's a lot of fun to have all these toolbox all these tools in our toolbox to individualize the treatment for a patient, exactly as we've seen here, Joachim. We also have, as I said, the combination with GLP-1 and SGLT2. There are also some countries that still use a lot of the combination with GLP-1 an insulin on board, so it's 1 injection per week. So the so-called fixed ratio combination, which also makes sense in some patients. More and more we do, although, use the free combination because you can push patients to a higher level with respect to the GLP-1 on board and thereby get a more pronounced effect. But there's no doubt that piling them together with GLP-1 and SGLT2 inhibitors, studies have showed that when you have this combination, you really have an added effect in respect to glycemic control. So the increase in glucose is not as pronounced. So I think worldwide, we had the backbone of the ADA ESD consensus guidelines. But of course, there are differences from one country to another based on what compounds are actually available, how are they reimbursed. But in general, with differences, of course, between Japan and Brazil and Europe, the backbone is still start early, be focused on comorbidities, often with metformin as a backbone. However, if patients have heart failure or chronic kidney disease or atherosclerotic disease, cardiovascular disease, we should start with an SGLT2 inhibitor or a GLP-1. So that was my major main take home from the treatment of many patients, but indeed also a patient as Joachim.
So Tina, things are changing so quickly now in terms of what's available in the clinic. So when you see a patient in Denmark in your clinic, and you have access to the incretin-based therapies, what characteristics might cause you to prioritize, for example, tirzepatide, which you talked about with the dual agonist, over a GLP-1 like semaglutide, for example?
That's also a really, really good question. And we are spoiled with the two compounds that you mentioned here, that they're really efficacious and clinical relevant effect. One of the things is, of course, do we have documented cardiovascular proof? So far, since we do not have cardiovascular outcome trials with tirzepatide, if it is a patient who has cardiovascular disease, I would do as you recommend in the guidelines, to use a GLP-1 receptor agonist as semaglutide to such a patient. However, if I have a patient who was very obese or very dysregulated without being at the left part of the guidelines, I would definitely consider tirzepatide early in the treatment algorithm, because I know that with a compound, that dual agonist, I would get a more pronounced effect in both HbA1c and also body weight reduction.
So Denise, coming to you, I mean, we've mentioned that there are different access, different guidelines in different parts of the world. Tell us a little bit about where the SGLT2s fit in Brazil and in your use.
Yeah, we have mainly the principal indication that we have in Brazil is for the public health system, is the one who have heart failure and above 65 years old. So it has to have this for the public health system. So we have to decide which would be the better for the patient, depends on the adherence and what they have the opportunity to use.
Okay, thank you very much. So we're going to move. So just to summarize the key takeaways, Tina, from what you've just shown us, that you reminded us are about obesity and type 2 diabetes are highly correlated, and both can be managed with glucose-lowering medications, the most effective of which, and you highlighted that in the ADA-ESD, is tirzepatide, semaglutide. You also showed us data that includes, the complexity of all the regimes now we have. Tirzepatide, the GIP, GLP-1 receptor analog, GLP-1s, fixed ratios as well, the daily fixed ratio combinations, and also use of GLP-1s, for example, in combination with SGLT2s. So let's go to the final session, Denise, and you're going to tell us a little bit about overcoming challenges in care through communication with people living with diabetes. This is such an important area, so I'm going to hand over to you.
So let's go back to Joaquin and see what he has to talk about himself and the interaction with healthcare professionals.
I think the most important thing with the doctors is that they explain you what they're doing and why they're doing. And I've been lucky of having a cardiologist and also endocrinologist that do that. Some of them, they think they know everything, and in fact, they know nothing. I like more the doctors that examine you and see your symptoms and try to deduct things from themselves than the ones that only look at this kind of thing. Doctors should explain why they do stuff, how they do stuff, and how it works. So you feel as part of the thing. No, you don't take the thing just to make the doctor happy.
So what we heard here from Joaquin is how it was important to have a good communication between the physician and also Joaquin to try to make him feel that someone who is in front of him was trustful. So effective communication is essential in overcoming many of the challenges we have or manage chronic diseases such as diabetes. So one of the very good tool that we have is motivational interviewing. It's a tool that we can build a better communication, a better relationship, and maybe we can encourage our patient to change behavior. We have 4 process of motivation interviewing, and in each step will be helpful to work with the patient. So we can use the strategy for engaging, focusing, evoking, and planning with our patient, and using this strategy to communicate and try to understand. So we can use open questions instead of saying, for instance, you want to lose weight or change in another. Are you ready to feel that you are prepared for changing habits? And try to not do affirmations, but try to change with him, validate something that he talk about. And reflection, like using reflection to walk through the things that we were talking, and then summarize and try to make it easy for him to be engaged with the conversation. But one of the things that is very important when talking about communications is you have to understand which is the patient that is in front of you, the person that is living with diabetes. Sometimes you have someone that is ready to make things happen. And on the opposite, you can have in front of you something that thinks that happens to me. So it's a different way and different strategies that you have to use with these different kind of persons that in front of you that are facing the difficulty of disease, just like obesity and diabetes. So sharing decision make with the patient is very important. So when you know the patient that is in front of you and you could engage the patient, you can try to use this strategy to share decision make and also to improve the glycemia control and also improve the quality of life of this patient, not only because a physician wants him to change, but he took part of the process. When we know that shared decision make is something that can improve the glycemia, improve the HbA1c, but it happens if you can engage your patient. And we have a lot of tools that we can use, for instance, videos, flip charts, workshop, questionnaires, things that can facilitate the way that we talk to our patients. And another aspect that Joaquin was telling us is how it was important in some part of the journey to have someone like a cardiologist or an endocrinologist or a dietitian that took part of his process. And we have to be prepared how to create a multidisciplinary management with patients that lives with type 2 diabetes. And it's important to know and how to decision make with all these patients and also the multidisciplinary team that with them. So that are some structures that we have to communicate with our patients, just like Joaquin.
So thanks, Denise. So all really, really important points, I think, in terms of that holistic approach. And Tina, I think one of the challenges now is that we have many treatment options, and we often have to make decisions in a chronic disease around intensification of those treatment options, or even de-intensification, stopping treatments. So when you manage people who you then have to suggest perhaps might need insulin therapy or might need to progress their treatment, do people see that as a personal failure? How do you communicate that need to intensify treatment?
Yeah, that's really a good question, because again, type 2 diabetes is extraordinary heterogeneous, and there are indeed patients that feel that when they go on insulin, they are major failures. So you really, in type 2 diabetes, as many other fields of being doctors, you really need to collaborate with the patient and really make sure that you do shared decision making. What I do myself, because we're challenged by patients who do not feel the disease, we are worried about them due to complications. We want to give them drugs that might be expensive. You might need to inject them, and you might even have side effects for a disease that you can't even feel. That's a real challenge. So what I do myself is to try to get a sense of where is the patient. Some patients just say, I will do whatever you do. But in spite of that, you need to explain why you do it. And I try to do my best actually to tell them about why I'm worried, to use mode of action. I tell them how these compounds work. I try to make them ready to what side effects are in front of them, but I really try to collaborate with the patient in order to explain them why I want to intensify their treatment.
Thanks, Tina. And I think, Denise, you really nicely explained to us about how you take into account the locus of control and the tools that you use for motivational interviewing and shared decision making. So what other tips do you use? Do you encourage patients, for example, to think about the issues that they want to talk to you about?
Yes, for sure. And I think the one of the aspects that I like to talk with the patient is what he has, the background that he has, and what he's trying to do, and what is the next step to try to understand about the disease to be engaged. So I'm always talking about for Joaquin, for instance, he has a long history of his father and the family. So I asked them, I asked about the disease and how it was, how was the difficulty that he had, and how he can change the history that he had, the background that he had. So a new history he can start. So that's the way that he has to change.
So thank you. And I think in this session, we really talk, the key takeaways is that people living with diabetes come to us for answers, but also understanding, and that the conversations and the interactions we have need to be positive, respectful, account for their locus of control. You talked about motivational interviewing, and we talked about 24-hour physical behaviors as well, and lifestyle interventions. And I think we also highlighted the need for multidisciplinary care, as many people live with multiple long-term conditions. So Tina and Denise, thank you so much for great insights, a really fantastic conversation. Thank you so much, both.
Thank you, Melanie. It was a pleasure to be on board.
Thank you, Melanie. And I cannot say anything. I have to thank for Mr. Borsani for sharing his experience. And thank you, Joaquin. It was great.
Yeah, thank you. It was so powerful to hear from somebody living with diabetes. So don't forget to download the slides and the accompanying practice aids. And we really hope that you feel more confident about applying the ESD ADA guidelines for holistic, individualized care for people living with type 2 diabetes. Thank you very much for participating.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/EYG860.